Welcome to EPG Pathshala on the subject Social Medicine and Community Health. I am Dr. C.P. Mishra, working as professor in the Department of Community Medicine, Institute of Medical Sciences, Banaras Hindu University, and I shall be discussing the module National Program for Prevention of Deafness. This module belongs to the paper National Health Programs and Policies. The development team for this module comprises of myself and other experts from the different parts of the country. The learning objective that has been set for this session is, number one, to understand deafness and its common causes. After going through this session, one should be able to tell the magnitude and problem of hearing loss, describe the objectives of National Program for Prevention and Control of Deafness in India, enlist components and activities under National Program for Prevention and Control of Deafness, and describe the organizational structure of the program. We all know that among the various dimensions of health, physical health, mental health, social health, and approaches to ensure them through prevention, primary, secondary, and tertiary prevention, disability ensures at the latter part of it, and reduction of disability is of paramount importance. Being conscious about this, Government of India initiated this program, National Program for Prevention and Control of Deafness, very recently. Now, hearing loss more than 40 decibels in the better hearing ear in the adults and 30 decibels in the better hearing children is considered to be disabling hearing loss. Now, hearing impairment, when it goes to the maximum extent, it leads to deafness. And in deafness situation, people are not able to hear. They generally pass signals to understand things. According to World Health Organization, over 5% of the population globally, 360 million people, out of which 328 million are adults and 32 million are children, have disabling hearing loss. 1/3 of the geriatric population, that is more than 65 years, suffer from disabling hearing loss. In India, 6.3% population suffer from disabling hearing loss. These facts and figures tell us that hearing impairment is a significant problem globally as well as in the Indian context. In order to prevent the disease, and understanding the various causes of deafness is required. The causes could be either congenital or acquired. Congenital causes are infections during pregnancy such as maternal rubella and syphilis. Acquired causes are low birth weight, birth asphyxia, use of medications, particularly aminoglycosides, cytotoxic drugs, anti-malarials, and some of the diuretics. Severe jaundice during neonatal period. Neonatal period is the period of the first 4 weeks of life, and severe jaundice during this phase may result in deafness. Meningitis, measles, and mumps. Chronic ear infections such as otitis media, quite common in our country, and if it is not taken at early stage, it will lead to deafness. Injury to the ear or head, exposure to excessive noise on a continuous basis for a prolonged period may lead to deafness. Prolonged presence of wax may also contribute to this process. Majority of these conditions, that is, which are causing deafness, are preventable or controllable. So, preventive strategies becomes more important. Government of India has launched the National Program for Prevention and Control of Deafness since July 2006 to June 2008 as a pilot project. And based on its success, it was decided that the subsequent expansions will be done. This pilot mode project was started with the objectives to prevent the avoidable hearing loss on account of disease or injury. Number 2, conduct early identification diagnosis and treatment of ear problems, responsible for hearing loss and deafness. Number 3, to medically rehabilitate persons of all age groups suffering from deafness. Number 4, to strengthen the existing intersectoral linkages for continuity of rehabilitation program for persons with deafness. Deafness requires rehabilitation, and rehabilitation is a process which requires multi-pronged and multidisciplinary approaches. The fifth objective is to develop institutional capacity of for ear care services by providing support for equipment, material, and personnel and their training. Training which will ultimately lead to skill upgradation. Now, components of the National Program for Control and Prevention of Deafness is: number 1 is manpower training and development. Number 2, capacity building for the district hospital, community health centers, primary health centers. Number 3, service provision, besides curative services, rehabilitation, if wherever needed, it should be done. And then awareness generation through information, education, and communication activities. Last but not least, monitoring and evaluation. Manpower training and development. Skill upgradation is thought to be one of the very significant input, particularly in these areas. Trainings are done for health staff and grassroots level people. Rupees 10 lakhs is available for training at district hospital level, and training modules is available for each category of staff. Training modules serve as a guide, and these modules can be used subsequently also by the different category of staff. Now, category of staff and their duration of training is projected here. Doctors and audiologists at the medical college level, 2 preferably head of the ENT department and another ENT doctor and audiologist, is sensitized about the national program for 1 day. The second category of staff, district hospital, ENT doctors and audiologists, a 3-day training is done. The basic emphasis is on skill upgradation of ENT surgeons for 2 days, audiologists for necessary skill upgradation. They are sensitized about the various programs, and they are also informed about the treatment modalities and other services that are needed to be provided. Pediatricians and obstetricians of the community health centers and district hospitals, they are sensitized for 1 day regarding causes that may lead to ear problems, including deafness in children, and also risk factors that are present in mothers which may lead to deafness. And they are also told about certain manifestations so that in case of need they can identify them and refer these cases. Doctors at primary health centers, community health center and school health schemes and industries are trained for 2 days as a sensitization measure, they are also informed about the various signs and symptoms and conditions that may lead to deafness and how to recognize them and how to manage them. Public health nurse, multi-purpose workers, male and female, Anganwadi supervisors and child development project officers in the district are oriented for 1 day so that they can identify cases, conditions which may lead to deafness or hearing impairment, and also create an awareness and inform people about the importance of these conditions. Also to inform people where services are available for this thing. Anganwadi workers, ASAs and TBAs, they are sensitized for 1 day, and then primary school teachers, particularly of science background, and parents of the hearing and speech deficient children, they are oriented for about half a day. It is very clear that the staff at the higher level, they take the training responsibility of the lower level. Now, as any measure of capacity building initiative, upgradation of infrastructure and manpower for the district hospital, community health centers and primary health centers in respect of ENT and audiology is undertaken. Funds are provided for provision of ENT equipments in the district hospital and primary health centers in rural and dispensaries in urban areas. Additional manpower in each district hospital is provided. One audiological assistant is also provided, and one instructor for the young hearing impaired person is incorporated in the system. Equipments that are provided at the PSC and CSC level: headlights, ear speculas, ear syringes, otoscope, Jobson horn probes, and tuning forks of 256, 512, 1024 Hz, and noise maker. In CSCs, pure tone audiometer is provided. Medicines kits that are provided are boro split ear drops, wax dissolving drops, antibiotic ear drops including cotton swabs, normal saline solution for used by health workers. There is a budgetary provision of rupees 20,000 per kit for PSC and 50,000 per kit for community health centers. At the district hospital, the inputs are microscope, 2 sets of microdrills with 2 handpieces and burheads, 2 sets of micro ear surgery instruments, pure tone audiometer, impedance audiometer, audio acoustic emission machine, sound treated room air condition, and budget of 20 lakhs are provided for is available for at the district hospital to start various activities. At the state medical college, surgical operating microscope for ENT use is there. Microdrill system and ear surgery instruments are there in 20 number. Indigenous digital audiometer is there. Impedance audiometer is there, and auto acoustic emission analyzer is also provided. Soundproof room by 8 feet into 8 feet air conditioned room is also there. Now, coming to the service provisions, including rehabilitation by the levels of care, it varies. At primary level of care, that is community health center, PSC, sub-centers, primary school teachers, health worker, panchayats, the emphasis is on early identification of cases of hearing impairment and their management, promoting public awareness in respect of prevention of deafness. This public awareness creates demand for these services and support to school ear care program. At secondary level, that is district hospital, these services are provided for management of cases, referred from PSC, CSCs, organization of ear care screening camps, school ear care program, training of PSCs, doctors, nurses, audiometric staff, and health workers and school teachers. Service provisions at tertiary level state medical colleges. The 2 ENT surgeons and 1 audiologist from the medical colleges are trained. Their functions would be training of manpower, that is sensitization program and surgical training workshops from district and down, management of referral cases, early detection, ear screening camps, medical and surgical treatment, and appropriate referral. These are the components, and rehabilitation of hearing and speech disorders and hearing and aid provisions. Awareness creation at all among the community. Early detection by healthcare functionaries at all levels, including family members, parents, selected school teachers, multi-purpose workers at sub-center level, public health nurse and medical officer in PSC, CSC district level, they play a very, very significant role in early detection of cases. District level pediatricians and gynecologists refer to the district ENT surgeon any child born of a high-risk pregnancy or delivery. School teachers are involved in screening the children. Ear screening camps conducted by PSCs and CSCs doctors and district level ENT specialists in collaboration with non-governmental organizations. One camp in a month in each district at different locations are generally organized. Treatment part, public health nurses, multi-purpose workers provide treatment of common ear ailments such as wax, acute suppurative otitis media under the guidance of a PSC doctor. Trained primary health center CSC doctors provide early diagnosis of ear diseases and treatment of all common ear ailments. The district level ENT doctors and audiologists provide comprehensive preventive, promotive and curative and medical rehabilitative services. The purpose is that the comprehensive health care, comprehensive ear care be provided. Referral services, patients with ear problems that either require surgery, hearing aid, fitting or rehabilitation therapy are referred to ENT doctors and audiologists at the district level. They prescribe surgery or hearing aids. Complicated cases that cannot be adequately handled at the district level are referred to the state medical colleges. Hearing aid provided in collaboration with Ministries of Social Justice and Empowerment in the 12th plan. Rehabilitation and hearing aid provision. The hearing aids will be issued under the ADIP scheme implemented by Ministry of Social Justice and Empowerment as per criteria developed for the implementation of the program. Awareness creation among parents, community. This is a very vital input. So grassroots level workers, healthcare functionaries at all levels. Several educational materials are like posters, pamphlets that are distributed for this purpose. Screening camps at focal point for awareness creation in the public health is organized. Advertisements as audio video clips in leading national television channels are available, and a budgetary provision of 20 lakhs at the state level and 2 lakhs at each district level for IC activities has been earmarked in the National Program for Prevention and Control of Deafness. Monitoring and evaluation of the program. Benefits of the various services like prevention, early identification, treatment, referral, rehabilitation for hearing impairment and deafness are monitored and evaluated. Decrease in the magnitude of hearing impaired persons is another indicator. Decrease in the severity extent of ear morbidity or hearing impairment. Then other parameter is improved service network for the persons with an ear morbidity, hearing impairment in the states and districts covered under the project. Awareness creation among the health workers, grassroots level workers, to the primary healthcare medical officers and district officers. Expected benefit of the program. The other areas could be larger community participation. To prevent hearing loss through Panchayat Raj institutions, Mahila Mandals, village bodies. In fact, these local institutions, Panchayat Raj institutions, Mahila Mandals, village bodies should be employed at different levels of participation. One, they should be involved in the planning of the program. They should be involved in delivery of the program. They should be made aware about promoting utilization of services. And lastly but not least, they should be also evaluate the services whether they are moving in the right path or not. Leadership building in primary health center medical officers to help create better sensitization in the grassroots level, which will ultimately ensure better implementation of the program. Capacity building in terms of manpower, in terms of infrastructures, in terms of supplies at the PSC, CSC and district hospital to ensure better care. Presence of state-of-art department of ENT at medical college in the state union territories so that the program can take it in the right direction. The district health society is the program implementation unit at the district level by coordinating different agencies and monitoring implementation of pooling in all the resources available. So district health society must be functional so that there should be all these stakeholders which are involved in the program, they should be utilized for this purpose. The progress of the National Program for Control of and Prevention of Deafness. The program was the 100% centrally sponsored scheme during the 11th 5-year plan. When we launched 12th 5-year plan, that is for the year 2012-2017, the central state, it is envisaged that during this period, 12th 5-year plan period, 2012-2017, the resources will be pooled from the center and the states. The program was initiated in the year 2007 on pilot mode in 25 districts of 11 states and union territories, expanded to 192 districts of 20 states and union territories, and in the 12th plan, it is proposed to expand the program to additional 200 districts in a phased manner so that entire states and union territories are covered by March 2017. Now, coming to the organizational structure of the program, we all agree that for paying optimum dividend, an organizational structure must exist. And this program, particularly National Program for Control and Prevention of Deafness, has a central coordination committee with representatives from Ministry of Health and Family Welfare Specialists. At the center, there is a central cell, a team of 2 national consultants, 1 program assistant and 1 data entry operator exists. At the state cell, 1 consultant, 1 program assistant and 1 data entry operator is there. Then State Health Society and Program Committee, which looks into the planning, implementation, and monitoring and evaluation of the program at the state level. State nodal officer is there, preferably an ENT surgeon or a program manager at the directorial level. Secretariat level provides technical guidance and expertise to the State Health Society to implement the program. Now, health is a state subject, and therefore it becomes important that the state health societies must take into consideration the planning, the management, and other parts. And at the district level, health society is primarily, district is the basic administrative unit, and district health societies have a very significant role to play in the implementation of the program at various levels. Now, this program, although started late in 2006 because there were other competing priorities in the country, although initially it was in the pilot phase, but it is envisaged that by the year 2017, it will be covering the entire part of the country. Now, just to summarize, disabling hearing loss prevalence globally is 5% of the total population. And in Indian scenario, it is more than that. National Program for Prevention and Control of Deafness in a phased manner with 100% central assistance. 12th plan to be contributed by both central and state governments. Capacity building of primary health centers, community health centers, district hospital, medical college in terms of infrastructure and manpower in the key input. Other activities are early detection of ear and hearing problems by screening camps and in and outpatient departments of health facilities, management and treatment of ear problems, provision of hearing aids wherever needed, and establishment of a referral mechanism so that cases get the optimum treatment, and training of manpower and other inputs, capacity building of the system to take care of the challenges of this program, and awareness creation is beyond doubt the most important activity. So the program is taking care of infrastructure expansion. The program is directed for capacity building of the various institutions that are involved in provision of the care, and systems have been kept in vogue so that programs can take up in a very nice manner. And there is equal emphasis or more emphasis on primary, secondary and tertiary care so that the program can take up. Just now we have discussed an overview of the National Program for Control of and Prevention of Deafness. You must realize that since the inception of the planning process in this great country, Government of India has recognized that health has various dimensions: physical health, mental health, social health, and so on. All mechanisms were evolved for prevention of diseases, and primary prevention received due importance. For this purpose, several educational measures have been initiated in the country from time to time. There are many competing priorities like vector-borne diseases, reproductive and child health, and so on. And with the remarkable success in the field of communicable diseases over a period of time, Government of India realized that disabilities, particularly physical disabilities and mental disabilities, are a serious challenge. Visual, auditory impairments are contributed mainly by factors that can be taken care by primary prevention. Auditory impairment is emerging as a significant public health problem. And this auditory impairment, the guidelines have been set, that is if there is a problem in adults at 40 decibels and in child population more than 30 decibels, they become the deciding cutoffs. However, impairment may be mild, moderate, and severe. When the impairment goes to the maximum level, the person becomes deaf. It means he cannot hear any type of sound even after on amplification. And pure sound produced by audio meters, even he is not able to perceive them. And he uses the signals and other methods of communication. Now, deafness or auditory impairment is a significant problem globally. It is estimated by, as I said earlier, that 5% of the total global population is likely to be a victim of deafness. In Indian context, the figures are much more than that. National Sample Survey Organizations from years to year has also highlighted this problem. So, in the old days particularly, those who are 65 years and above, auditory problems, particularly hearing problems in them is of very significant magnitude. More than 1/3 are victims of this. Looking at this scenario, that is the total burden of disease in terms of deafness, and looking at the various causes which could be congenital and which could be acquired, it was observed that most of the deafness are caused by those causes which can be prevented, or at least which can be managed or which can be controlled. And therefore, Government of India, while launching this program, it was very serious that the first and foremost input should be awareness building. And awareness building should be inbuilt system at different layers cares. At the grassroots level, primary school teachers and community members have been identified as a change agent, making people aware about the various eye problems that may ultimately lead to deafness. So a mechanism has been evolved that not only school teachers, particularly of the science background, will educate people, they can also screen children, they can also identify children who have the problem, and they can be referred to the appropriate authority. It was realized that There should be sensitization, there should be skill upgradation of various category of staff which are involved in provision of ear care, and necessary measures, necessary training inputs have been provided for that purpose. Even if the persons are trained, persons are skilled, without provision of medicines and other equipments, there will be no improvement. So necessary inputs in terms of logistic support have been extended. So besides capacity building and logistic supports, a mechanism of referral has been established so that optimum services can be developed at particular point of care. So attempt has been taken by in this program in terms of various inputs, processes have been established, monitoring and systems have been evolved so that the program can move in the right direction. It is envisaged that during the 12th plan, the program will be expanded in a phased manner, and by 2017, all the districts in the country will be covered under the ambit of National Program for Prevention and Control of Deafness. The prevention of deafness is a challenging task. However, with concerted efforts, it's likely that we'll be able to achieve the goals stated, objectives stated in the program. Thank you very much for visiting EPG Pathshala.